I will hand it over to Kate to. Thanks so much.
Sure. Hi, welcome. My name is Kate Ingman. I'm with the Community Health Plan of Washington, and I'm going to begin with a land acknowledgement. So as we gather from across the state, I'd like to personally acknowledge that my home is located on the traditional lands of the Suquamish people and use the land acknowledgement provided by the tribe. Every part of the soil is sacred in the estimation of my people. Every hillside, every valley, every plain and grove has been hollowed out by some sad or happy event in days long vanished. Chief Seattle, 1854. We would like to begin by acknowledging that the land on which we gather is within the ancestral territory of the people of the clear salt water, Suquamish people. Expert fishermen, canoe builders, and basket weavers, the Suquamish live in harmony with the lands and the waterways along Washington's Central Salish Sea, as they have for thousands of years. Here, the Suquamish live and protect the land and waters of their ancestors for future generations, as promised by the Point Elliott Treaty of 1855. Thank you.
Thank you so much, Kate. And I'll kick us off. My name is Scott Swan. I'm with Molina Healthcare, and we're going to walk through some of the changes in House Bill 1860. We did do this presentation back in December, and it took us a whopping 10 minutes to go through the slides, and then we had a robust Q&A section. So we'll quickly go on a brief overview of what the changes entail, provider and MCO responsibilities, and then we will move into our Q&A section. Where we did compile some of the frequently asked questions, and we do have some responses ready too. So, as folks are aware, House Bill 1860 did go into effect January 1st of this year. And as most people understand, it now has new requirements for MCOs in order to assist our members that are experiencing homelessness in providing housing supports and resources. It requires that there's notification within 24 hours from any inpatient behavioral health facility, which there will be more info on the next slide about. But if you'd like to review the legislation, it's right at the bottom of this slide. And yes, these slides will get sent out. We're going to get our frequently asked questions fully approved before those get sent out and attached with the slides too. So it might take a few days, but we will be sending out all slides and a list of frequently asked questions and answers within a few days of the conclusion of this webinar. As I alluded to previously, this new House bill has a 24-hour notice. The notice can be more than 24 hours in advance. Ideally, discharge planning starts at admission. And so as much time as possible that MCOs can be alerted that a member may be in need of housing resources and support, and accessing those resources, the better. In order to have the best outcomes. One question we did get quite often is if we are notified at admission or earlier than 24 hours, does there have to be another notification at 24 hours? And the answer is no. There's one notification that needs to happen 24 hours or more prior to discharge. And then through the process where providers will put in the subject line of the fax notification sheet that it states that a member is experiencing homelessness and could use supports is the requirement. So that's how we will be alerted, and that's how providers can alert us that there's a member that housing is an unmet need. And this allows us to just get as many supports and resources over to the member as possible, and also increases communication. Since if the member is experiencing homelessness, we may not have an address on file, we may not have a working phone number. So it's best that we can connect with the member while they're still inpatient and able to connect with us. So I will pass it over to Kate.
Sure. So as Scott mentioned, as you're identifying individuals as they come in for admission, if they have a housing need, you can send that notification to the MCOs. So as early as possible is ideal. And then you collaborate with the MCOs over the course of their stay to help identify any discharge planning and housing related needs. And then the MCOs will continue to assist the individuals connecting to housing resources and accessing stable housing. Next slide, please. So how to identify the MCO. So this isn't a big change. Basically, you'll include the housing information on the notifications that you're already sending. So the requirement is 24 hours prior to discharge of notifying of the housing needs, but as we mentioned, as early as possible. But we just have the details here that it's included on the faxes that are already sent. So including the housing information on the fax notification is where that will go. Next slide. And then we wanted to include the contact information for all of the referrals to case management. So this is just another level of support that can be available for individuals. So if you see complex needs or feel like an individual would benefit, we just wanted to make sure you had the contact information to make a referral to case management within each MCO. So feel free to make referrals in addition to the notification about housing. I'll pass to CJ.
Hello, I'm CJ, James Bruner with Community Health Plan of Washington, and I'm going to go over things to keep in mind. So just as you're working with our members in a hospital setting, want to keep in mind that it's really important to have that member's voice and choice while making decisions about discharge planning and care and housing needs. And member is ideally clinically stable as we're going through this process, stable enough to making sure they're stable enough to make those choices. And just a reminder that referrals start while the member is an inpatient, and then we want to have a warm handoff to any outpatient providers in the MCO. And referrals prior to discharge may depend on length of stay and referral options. Inpatient behavioral health providers to verify with member if there are any housing programs currently in progress for that member. And if yes, just explore what that housing option is and just communicate those follow-up needs for that individual. Here are some statewide resources for potential housing options. Through DSHS, HUD, US Gov, regional resources, King County, Home and Community Services, and the Foundation for Community Support Programs. So these are some main housing resources for Washington. I think that is our last slide. And if there's any questions, we are here to answer.
Yeah, thank you so much. And like we said, yeah, that's all we got. So we'll go through some questions and please utilize the Q&A function just to ask any and all questions. First one I can see is from Anita and it says, how do you want it on the web portals you noted? I'm going to be honest, I'm not sure what the question is on the web portals. The way that we'll be notified is through the subject line on the UM notification. Not sure if I see both of you went off mute, so I'm not sure if you have something to add. Yeah.
We do have a web portal, it's Community Health Plan of Washington that we encourage our providers to utilize. And if it's not already indicated within the clinical information, you can also add it within the notes section of the web portal.
Thank you. The next question is, as an inpatient provider, if a patient is homeless still on discharge day, can we keep them until housing is secured? Unfortunately, we did confirm that having housing as an unmet need is not clinical criteria to have a continued stay. So if a member is experiencing homelessness, it is not clinical criteria to keep them more than what is clinically indicated. Yeah. Anything else either of you would add?
Yeah, I just want to emphasize if you are in that situation, just to communicate with the care coordinator, UM reviewer, that there is housing, because we do follow up with everybody after they do discharge with our transitions of care, and we can help make those connections.
Thank you. The next one, oh, this might be an answer to it. It would be an authorization request note section. Yes, that is correct. Next question is, are the case management email contacts specific to behavioral health teams within MCOs? Or are they general contacts? They do go through our case management inboxes and then they get triaged to the appropriate teams. So if a member is marked as needing behavioral health, at least at Molina, and I believe this is for all MCOs, it would go to a behavioral health case manager that can help out and assess that member. So And then Anita just thanked you, CJ. So you're welcome, Anita. The next is from Renita. Will the MCOs be funding their members' housing? Well, House Bill 1860 did build in some notification parameters, did not allow for additional funding or resources. So MCOs will not be funding members' housing because that's not within the state plan and we wouldn't be able to. However, this will allow for some better outcomes since we can have better planning and better outcomes while a member is inpatient and we're able to connect and communicate with them. Anything either of you would add on? Yeah. Thank you. And then the next question from Kelly is an excellent question that we have not gotten full answers on, but what are the consequences if the notification is not made? We're still exploring that, but this is within the contractual requirements and this House bill does reference that. So that's going to vary by MCO2, I believe, just in what's in the contracts and what the consequences for not complying with the contractual requirement would be. We are going to get a better answer and have that one on the frequently asked question sheet too, that we can distribute afterwards too. So we don't have any remaining questions. So if anybody has any, we're going to hang out here for a little bit longer just to allow for more questions. Just for some context, yeah, we only had 9 at this time, and the last time we did this, we had 42. So if there are any questions, please ask them. I'm also going to pull up our frequently asked questions and some of our preliminary answers, and we can go through those too if there aren't any other questions, but we'll keep an eye out for those.
I do want to add on, CJ, a little bit onto that last question around what if we don't notify you guys, the MCOs? Well, we will be working with each provider if we do see that there's a pattern of no notification or discharge date. So we just want to work with you to see how we can help you improve the notification, because it is really, really important for us to be able to reach the members timely once they do discharge. So we will be collaborating with you.
Thank you, CJ. Gotten a few questions. So the next one is, what supports are offered by the case manager through the MCO? And typically the supports are connecting to resources. They can connect members to whichever level of care is appropriate and help get them connected to providers that are in network for their MCO. We connect with members on a regular cadence too, just to see what any unmet needs are, do some care planning with them, and just to help them have the best outcomes and be able to access medical care. What more would either of you add, if anything?
It's hard to give specifics because it really depends on the individual need, but they might be connecting them with more programs within each of the managed care organizations or programs outside of that. So it can be pretty variable how case management offers support.
Mm-hmm. Definitely. Thank you. The next question is, will opioid diagnosis codes be taken into consideration for this bill and not discharged to if housing is not available? We run a higher risk of homeless reusing if discharged too soon. This bill and process applies to inpatient behavioral health admissions. So it would be definitely dependent on the case if it was an admission to an inpatient behavioral health facility versus an SUD treatment facility, since this bill applies to inpatient behavioral health. However, like we brought up earlier, and yes, please do reach out to the MCO because there can always be something worked out if a member is going to discharge into homelessness, whether that being that they do have a date that they can enter into a housing resource or whatnot. Please do reach out to us as soon as possible. There can always be, we're here to work with you and see if, sometimes there could be admin days or whatnot too, if that's going on. But anything else either of you would add? Okay. Can you give examples of what the coordination would look like from the MCOs, making referrals for medical respite or shelters for MCO members experiencing homelessness? The coordination would, look like us bringing resources to that member, depending on the case manager too, doing some outreach to those facilities, or supporting the member in doing so. Yeah, I'm trying to think of more, and it's not coming to mind. Either of you have some more you would add.
Yeah, I just want to add to, just as much as the importance of the inpatient provider to work on homelessness, it's going to be really important too to make sure that that individual does have an outpatient provider as well. So that is another piece that will help connect to that outpatient provider. So there can be a more in-depth follow through with once they do leave the facility. But the big thing is really around communication and just making sure we're having that conversation with each other.
Thanks so much, CJ.
Mhm.
The next question is, would it be beneficial in the beginning of services that every patient contact you? Yes, in order to have the best outcomes for our members, the referral to case management come from the member or from the facility. And like we said, it's discharge planning begins at admission, and for the best outcomes for our members, especially those experiencing homelessness, it's beneficial to connect with us as soon as possible. So, thank you. The next question is, can you give examples of what your MCO services is, etc.? I believe we've kind of touched on what case management offers. Not sure if there's anything either of you would add to that.
It's hard not to do it plan specifically, so I feel like keeping it at the general is probably best. But then I think if you see individual needs with an individual, it's always good to have a conversation with the MCO directly, because all of us offer different programs.
Yeah. Thank you. The next question is there a specific form or format needed in providing the needed information to the MCOs? So the notification will be on that fax cover sheet, notifying us of admission, and then it would be on the subject line. You would highlight that housing is an unmet need. And then you could either put notes on there for referral to case management, or you could outreach the email that's directly in the slides too. And then we can work from there. So anything else you would add? Okay. Next question is, if patient is enrolled in supportive housing with foundational community supports during their inpatient stay, would this be a similar or duplication of services? If I'm understanding the question right, it doesn't sound like housing would be an unmet need at that time, correct? Or I saw you go off mute, Kate, not sure if you had. Yeah.
I think that was my understanding as well. So if they have housing already lined up, that's like they're in the process of housing being secured, I think you might problem solve with the MCO if there's any interim need, is what I would take there. That's my understanding of the question.
Yeah.
I apologize if I'm missing it.
Do let us know, Dre, if we're missing the question. But we did get this question too, is if there's required notification if a member is housed. No, House Bill 1860 only applies if a member is if housing is an unmet need. So there's no need to notify us that a member is that they're housed and it's not a need. So does this bill not apply to inpatient SUD treatment? That is a good question. For the sake of right now, it definitely applies to inpatient behavioral health facilities. It does not state when we reviewed the language, it doesn't state SUD facilities explicitly, but we are getting clarification, and that'll get sent out in the frequently asked questions. And a question from Michelle. Hi, Michelle. So for the AIAN population who choose not to enroll with an MCO and choose to stay on fee for service, who would be an inpatient provider reach out to for care coordination? It's a good question. Unless either of you know off the top of your head, I think we're gonna have to take that question back and get that out to everybody. So thank you so much. I'm gonna add it to our list now. So thank you so much, Michelle. You're highlighting something that I don't think we covered last time. And thank you for your patience while I copy and paste it. And there we go. The next question is, does this only apply to inpatient behavioral health and not SUD? We did address this previously, and we are going to get more information on this, but At this time, what we can speak to is that it definitely applies to inpatient behavioral health admissions. We will get that on the frequently asked questions that we'll send out soon. Next question is, understanding what resources the MCOs actually have to offer is really helpful for us at hospitals so that we can encourage collaboration. So any way you can give us ways to sell this new requirement helps make this more something that may actually be useful rather than checking a box. So anything you can tell us that may be a carrot. A few of the things I would add is that if we can get a member connected with us into case management, is that they will have better access to services. Other unmet needs can be worked on too if they're seeking a different level of care or an outpatient provider or whatnot. We can get that member enrolled and they'll have better outcomes and they'll have support in navigating and participating for PAR providers. It also could, in some cases, allow a member to get connected to us and we could share a housing resource, which, as we know, housing resources are in quite demand, but there are situations where we may be able to be successful and get a member into housing prior to discharge or get a resource lined up. So not sure if there's anything either of you would add as kind of what's the benefit of connecting with the MCO beyond meeting a requirement.
I always, when I'm talking with an individual, I always say that it's another person working on your behalf to help you connect to things. So it's another person aware of your needs and another person that can help advocate and connect you to what you might need. So I think that the case management might have connections that their outpatient provider isn't connected to or something like that, just that can be another level of support that they might not know what resources we could connect them to. So that's where I start.
Thank you so much, Kate. Next question is, when we have been denied services by the MCO, personally, even during review, homelessness has not been a factor for the department. Will these case managers be able to advocate in these situations, or are they completely separated? That's going to vary MCO to MCO, but our case management team can connect with to kind of discuss what's going on and make them aware of the situation. However, I don't want to speak specific for all MCOs on kind of how that process would look or how they could advocate. Not sure if there's any more broad statements either of you have on that.
Yeah, I would just make sure that you are checking in with each MCO because we all have our our own ways of work processes. For Community Health Plan of Washington, our and care coordination team is all interconnected, so that one person will be following from the beginning of the authorization through any care coordination, housing needs, but definitely check in with that specific MCO.
Thank you so much. Next question is work being done with the tribes to see what resources they have for tribal clients? I'm not aware of anything off the top of my head, so I'm adding it to our list of questions. I'm not sure if either of you have anything to add on that, but I haven't seen anything specific to work collaborating with tribes on this. Yeah, so
Similar with you, Scott. I haven't seen anything specific.
We will get info for you. I have it on my list of questions. So. And then next question is, as a case manager, are we required to document when a client is homeless in our case management notes? I don't think these requirements would impact the way you take notes or chart. Yeah, so it only applies really to that inpatient notification cover sheet that we get. We're not going to be like auditing notes or anything like that to ensure that a member's unmet needs are highlighted. So I hope that answer made sense.
Yeah, but I mean, as a case manager in a clinical setting, that's a social determinant that as you're working with that individual that should be addressed. So however that's carried through in your documentation, how you're following up that need would be helpful for us.
Thank you. We have 2 minutes left, but we don't have any more questions. So if there are any more, please do ask them. I'm going to look over our frequently asked questions and kind of go through them. I'm just reading them through to see if there's any that we want to cover.
Scott, we could highlight that this also applies to youth discharging to homelessness. And so we're highlighting a couple of resources in the FAQ, but just wanted to call that out, that youth are also fall in this catchment.
Yes, thank you so much, Kate. That is a question we've got asked is, does this apply to youth and what resources will be shared? And yes, this does apply to youth, and there will be some, we can always share resources that are specific to youth, whether that housing resource, you know, if there's an age of a maximum age that folks can access, then we'll definitely be sharing those resources. And we're just gonna ask, when referring to inpatient, is residential level care apply? As we brought up earlier, we are going to get this answer fully ironed out and sent out to everybody. Just as it states inpatient behavioral health admissions. And when we looked through it, that's the language it utilized. It did not state residential. So we will get a firm answer sent out to everybody after this presentation. So answering that question, we are at time. So as we got another question, we'll try to answer it. So if folks do have to go, please, we are at time, but do the MCOs have new housing specific to this requirement? Are you accessing the same housing resources available in the community? Yes. This new house bill did not provide additional resources, and MCOs don't provide housing. So while this legislation does increase the communication regarding a housing need, it doesn't provide additional housing resources. So it'll be us increasing access to the housing resources available in the community. So if there are any other questions, please do ask them, but we are out of questions. So we'll give it another minute or so, but one question we did get asked that I'd like to address too is we were asked, how will this data be compiled on housing rates and provided to legislation, or will it be entered into a centralized database? And housing information is captured and reported to HCA utilizing the behavioral health supplemental data. And so at this time, there's no additional reporting requirements. Another question we got asked often is, will there be a new fax form provided? No, we'll utilize the same fax form you've already been using, and you'll just highlight it in the subject line. So since it is 12:30, we will wrap up for now. And like I've said a few times, we will get these frequently asked questions over to everybody as soon as we can. So just making sure we get everything approved. So we'll be sending out the slides and the frequently asked questions. And thank you so much for taking time out of your really busy schedules to join us to cover House Bill 1860. Thank you so much.
Thank you.